Welcome back. In our last lecture, we focused on evaluating the intrinsic properties of a diagnostic test, its sensitivity and specificity. Now we're going to bring that knowledge into the exam room. This lecture is all about the practical application of test results for an individual animal. How do we formally combine our clinical suspicion with a new piece of information from a lab test? The key to this is Bayes' theorem, a fundamental rule of probability that tells us how to update our beliefs in the light of new evidence. We'll learn how to use likelihood ratios, which are a powerful prevalence-independent measure of a test's performance. We'll see how to go from a pre-test probability of disease to a post-test probability, and even how to do this for tests with multiple result categories. This is how we turn a simple test result into a confident clinical decision. In herd health, every diagnostic decision begins with pre-test probability. This is your index of suspicion that disease is present before you even collect the sample. It's not guesswork, it's built on evidence. First, the clinical picture. Are we seeing calves with diarrhea in the high-risk neonatal period? Production stage, species, and age are strong predictors. Second, think about local prevalence. Is this disease known to circulate in the region, or is it a rare exotic? For instance, a sudden vesicular lesion in cattle in an FMD-free country is viewed differently than in an endemic area. Third, we must consider herd and referral bias. A farm submitting samples to a reference lab has already been preselected for higher suspicion compared with routine surveillance in a low prevalence area. And finally, the production system shapes risk. Backyard flocks face different exposures than intensive poultry farms. This starting point is essential because it drives how much weight you should give to a positive or negative test result when making decisions. So how do we formally update our pre-test probability? The most powerful tool for this is the likelihood ratio. And likelihood ratio tells you how much a given test result should shift your suspicion. Unlike predictive values, likelihood ratios are prevalence independent, making them a stable and transferable measure of a test's diagnostic power. The positive likelihood ratio answers the question, how many times more likely are we to see a positive test result in a truly sick animal compared to a healthy one? It's calculated as the sensitivity divided by the false positive rate, which is 1 minus specificity. The negative likelihood ratio tells us how likely a negative result is in a sick animal versus a healthy one. It's the false negative rate, 1 minus sensitivity, divided by the specificity. These two numbers contain all the information we need to interpret a test result. To put this in connection with other test properties, this cheat sheet visualizes the relationship between a diagnostic test and true disease status. As seen, the core comprises the 2x2 table. Likelihood ratios are the most clinically useful metrics here because they tell us how much a test result should shift our suspicion of disease. Positive likelihood. Ratio. Calculated as sensitivity above 1 minus specificity indicates how much more likely a positive test is in a sick patient versus a healthy one. Negative likelihood. Ratio calculated as 1 minus sensitivity above specificity indicates how likely a negative test is in a sick patient versus a healthy one. In short, positive likelihood ratio helps confirm the presence of disease, while negative likelihood ratio helps confirm its absence, independent of disease prevalence. Let's explain how to utilize likelihood ratio bands as a quick guide for diagnostic decision making. If a test result falls within the positive likelihood ratio in 1 to 2 range, it provides a minimal change to the post-test probability, meaning a positive result does not definitively identify a persistently infected animal. However, a highly effective diagnostic tool with a positive likelihood ratio greater than 10 offers a significant and often conclusive change, allowing a producer to confidently rule in the disease and remove the animal from the herd to prevent further transmission. When the goal is to confirm an animal is disease-free, the negative likelihood ratio bands become the primary focus. A negative likelihood ratio of 0.5 to 1 provides only a minimal change, which is insufficient to safely introduce a new bull into a clean herd. A test with a small to moderate change may lower suspicion but remains inconclusive. Ultimately, a test result with a negative likelihood ratio less than 0.1 provides a significant change, allowing the veterinarian to confidently rule out the infection and certify the animal as safe for the rest of the livestock. Let's calculate the likelihood ratios for the BVD ELISA we validated in the last lecture. We determined its sensitivity and specificity were both 95%. To get the positive likelihood ratio, 0.95 divided by 1 minus 0.95, which is 0.95 divided by 0.05. The result is a positive likelihood ratio of 19. This is a fantastic number. It means a positive result. It's 19 times more likely to be seen in a truly infected animal than in a healthy one. Based on our rules of thumb, and positive likelihood ratio greater than 10 provides very strong evidence to rule in a disease. For the negative likelihood ratio, we get 1 minus 0.95 divided by 0.95, which gives us a negative likelihood ratio of 0.33. This is also a very powerful result. Since it's well below 0.1, it provides strong evidence to rule out the disease. This test is excellent for both ruling in and ruling out BVD. Do not forget that for these calculations, there are applications that make life easier. So how do we use the likelihood ratio to get our final probability? We use Bayes' theorem. While the full probability formula is a bit clunky, there's a much simpler way to do it using odds. The odds of an event are just the probability it happens divided by the probability it doesn't. The Bayesian calculation then becomes incredibly simple. Your post-test odds are simply your pre-test odds multiplied by the likelihood ratio for the test result you got. The workflow is 3 steps. First, take your pre-test probability, your clinical suspicion, and convert it into odds. Second, multiply those odds by the appropriate likelihood ratio for your test result. If the test was positive, use the positive likelihood ratio. If negative, use the negative likelihood ratio. This gives you the post-test odds. Finally, convert those new odds back into a probability, and that's your final answer. That is your new updated level of certainty for that animal. Let's walk through a realistic clinical scenario. A 1-year-old cat is presented with a fever and fluid in its abdomen. The signalment and clinical signs are highly suggestive of feline infectious peritonitis, a difficult disease to diagnose. Based on your experience, you estimate a pre-test probability of about 30%. First, we convert this to odds. 0.3 divided by 0.7 gives us pre-test odds of 0.43. You perform a Rivalta test on the fluid. It's a simple in-house test. It's not perfect, but it's known to have a moderate positive likelihood ratio of about 7. The test is positive. Now we update our odds. We multiply our pre-test odds of 0.43 by the positive likelihood ratio of 7, which gives us post-test odds of about 3. Finally, we convert back to a probability. 3 divided by 1 plus 3 gives us 75%. That single simple test has allowed us to move from being suspicious at 30% to being quite confident at 75%, which may be enough to guide the next steps for the patient. Doing these odds conversions can be tedious in the busy clinic. Fortunately, there's a brilliant graphical tool called a Fagan nomogram that does the math for you. It consists of 3 vertical lines. The line on the left represents the pre-test probability from 0 to 100%. The middle line is a logarithmic scale for the likelihood ratio, and the line on the right shows the resulting post-test probability. To use it, you just take a ruler or any straight edge. You anchor one end on your pre-test probability, in our last example, 30%. You pivot the ruler so it passes through the likelihood ratio of your test, in our case 7. Where the ruler crosses the line on the right is your answer. It will land right at 75%, just as we calculated. This is a fantastic tool for doing quick chair-side updates to your diagnostic certainty without ever touching a calculator. In addition, there are several mobile and web applications that are available to automate these calculations and instantly convert pre-test probabilities into post-test probabilities, like our example worked out in Epi Toolbox app. One of the biggest advantages of likelihood ratios is that they free us from the limitations of a single binary cutoff. Many of our tests, like an ELISA for Jones or a somatic cell count for mastitis, give a range of results. Instead of just calling them positive or negative, we can define several categories and calculate a unique likelihood ratio for each one. Let's take the mastitis example. A very low cell count gives us a negative likelihood ratio of 0.3, which moderately decreases our suspicion of mastitis. A borderline result gives a likelihood ratio of 1.2, which tells us that this test result is almost useless and doesn't change our odds much at all. But a very high cell count gives a positive likelihood ratio of 4.5, which substantially increases our post-test probability. By using these multi-level likelihood ratios, we are squeezing every last drop of diagnostic information out of the test result, far more than we would with a simple positive negative classification. Let's do a worked example with a more complex test. Imagine we are doing surveillance for bovine tuberculosis and we're using a Western blot as a confirmatory test. The pre-test probability for an animal is 5%. Our lab has defined 3 result categories and calculated a likelihood ratio for each. A completely negative blot has a likelihood ratio of 0.1. A blot showing just a single, non-specific band has a likelihood ratio of 2.5. It slightly increases suspicion but isn't conclusive. But a result with multiple specific bands is very powerful, with a positive likelihood ratio of 25. If our animal comes back with the multiple bands result, we can calculate its new probability. Our pretest odds were 0.053. We multiply this by our strong LR of 25, giving post-test odds of 1.325. Converting back gives us a post-test probability of 57%. We've moved from a 1 in 20 chance to a better than 1 in 2 chance, providing strong justification for classifying this animal as a reactor. The process we've just been following, starting with a prior belief, adding new evidence, and arriving at an updated belief, is the essence of the Bayesian paradigm. It's a fundamental way of thinking about science and learning. In our clinical context, our prior belief is the pre-test probability we have for the animal. The new evidence is the data from our diagnostic test, summarized by the likelihood ratio. And our updated belief is the post-test probability. This isn't just a one-time calculation, it's a dynamic process. The post-test probability you calculate today after a physical exam can become the pre-test probability you use tomorrow when you interpret a blood test. It's a continuous logical framework for integrating multiple pieces of information to arrive at the most rational conclusion, and it mirrors how experienced clinicians think intuitively. What should you take away from this lecture for your day-to-day practice? First, be acutely aware of your starting point. Know your clinic's baseline prevalence for common diseases. Referral bias is real and it dramatically changes the interpretation of every test you run. Second, try to think in terms of likelihood ratios, not just sensitivity and specificity. They are the engine of diagnostic reasoning. Third, whenever possible, embrace multi-level results. Don't just settle for a simple positive or negative when the lab gives you a quantitative value. Using category-specific likelihood ratios allows for a much more nuanced and accurate interpretation. Finally, make it easy on yourself. Print out a Fagan nomogram and keep it in your pocket or on your desk. It's the fastest way to turn a test result into a confident clinical decision. See you in the next lecture.